Thanks. So, getting the tissue out of the OR into pathology really is a partnership between neurosurgery and pathology. And Dr. Santi and I have been together for 14 years. And she's a great partner and friend, my fashion consultant and Italian tutor. But she's been this doesn't happen without pathology. You can't, actually the surgeons probably have the easiest job. We heard how wonderful the coordinators are, and that's what starts it. But then getting it out of the OR and up to pathology quickly is important, as we've seen changes, as we've been talking today all about the different multi-omics that we're doing. Like DNA is very stable, but RNA, the protein, if you're doing all these multi-omics, time matters. And not only do you want to be quick to avoid degradation, but you also want to make sure that you're basically doing it very similarly to limit what we call batch effect. And so, as you heard from Matoush, it's not just the tissue. We do liquid biopsies as well, but when we get the tissue up there, our pathology colleagues will quickly look at it, process it, and they're also dealing with the blood, CSF, and also organoids, which is even a separate workflow from the CBTN that we're doing. So now I'll let Dr. Santi talk a little bit about what she does. And also, this is to keep us on time. So if you know anything about surgeons and pathologists, whenever we don't get the answer we want, we just blame pathology. So if she goes over, I'm going to blame pathology.
So traditionally, the tissue that arrives to pathology has been fixed in formalin. So here highlighted the difference and the pros and cons of frozen tissue versus paraffin fixed tissue. For the classical pathology, we prefer the paraffin fixed tissue because it's perfect morphology and to give the final diagnosis, and is very good for immunophenotype. However, the yield and the quality of nucleic acid that you can extract is lower than the yield and the quality if you use directly the frozen tissue. And of course, in paraffin fixed tissue, the enzymatic activity, so the protein, are basically lost. To do proteomic out of paraffin fixed tissue is definitely difficult. So these are the advantages of the frozen tissue that allow for good quality extraction of RNA, DNA, and to study if frozen very quickly the protein. So why it is, however, complicated to freeze the tissue? But first of all, keep in mind that infectious organisms may remain viable. They are not viable in formalin fixed tissue, so universal precautions are necessary when handling the frozen tissue. Then for the classical hospital, to freeze and to maintain in this -80 at least freezer is much more costly and cumbersome. That put the tissue in formalin, created the paraffin blocks and keep in a room and -68 Fahrenheit degree, and they can stay there for years. This is what the FIP here, the collection that started back with the Civil War. And this is how they actually sequence the famous pandemic of the beginning of the 20th century. So a medical center like CHOP, we have this freezer, we have 4 in pathology, but is not all the center can do that. Then inside this freezer, you need to monitor them. If they, open and close, in reality, mainly with the RNA, probably their stability is less than 5 years. And then you have to deal with the liquid nitrogen that, as even some of the people of the CBTN know, sometimes you can have some supply tank explosion or serious risk of burn with the liquid nitrogen. So for the RNA preservation, though, is extremely good. For the protein preservation is a requirement, and is a requirement to freeze quite quickly. try less than 30 minutes from the moment in which the tissue comes from the OR. For RNA, there are differences. It depends on the type of tissue. And there are studies that have reported that RNA can withstand even a warm ischemia up to 24 hours for some tonsil tissue, probably from some muscle tissue, and it depends on the type of the tissue. For brain tissue, I would say that 24 hours is very long. But for the protein, I would say here I found a study for the Breast Cancer Foundation, less than 1 hour. For brain, less. The NIH required 30 minutes. So, and how quickly must we freeze the specimen? As quick as possible, and here is mainly a huge problem with the post-mortem donation. Remember even that there are a variety of factors that influence the post-mortem donation, including what happened in the last moment of life, how much hypoxia and ischemia there is in the brain. And this can have an impact mainly on the protein. Of course, the impact is minimal on DNA, is very high on protein, and let's say intermediate from RNA. Even from the tissue, they arrive from the OR, and this Dr. Storm can tell you there is the problem of the warm ischemia.
Yeah, so what ends up happening, right, what we usually like to do, and this is where it actually takes a good relationship with your pathologist, because they need the tissue to make the diagnosis, right? That's the most critical. That's the priority of the tissue. But what we like to do at CHOP is the minute we see it, we will send it up. We try not to devascularize it. We'll just take a big piece and say, look, send it right up, and this is for the study. It's okay, go ahead and process it. I promise you there'll be plenty of other tissue to make the diagnosis. And so that's why you do need a good relationship with pathology to make sure that happens, because we don't want it sitting on the back table for a long time, nor do we want it sitting up in pathology. So everybody's ready for that tissue.
Yes, and so basically the warm ischemia is considered the time from the basically the amount of time that the tissue is at ambient temperature and has been resected and arrived in pathology and is processed in pathology. Now, there are some hospitals, I'm not sure that is done at CHOP, and Dr. Storm can confirm that in DOR, put immediately the tissue inside some wet ice and they keep it in the refrigerator. Do you do that? No. They try to send it down to us, but you can find it in some paper. So you will talk about warm ischemia, cold ischemia. And as Dr. Storm, noticed before, you need a team work in order to have everything done as quick as possible. And we have tried, and in our best day, when everything goes perfectly, we were able to do in 20 minutes.
Yeah, it's been, again, it does take a team. And so when we walk in there, as part of our pre-op huddle, before the patient's even in the room, you know, it's really great because all the nurses are so invested at CHOP. And part of the huddle is, are they consented for CBTN? Are they consented for liquid biopsy? And by the time I get in the OR, as they're intubating, once they're asleep, you know, all the bloods are drawn. Matusha's team has been contacted, and it's anesthesia, nursing, all working together. And they'll call for the tech to take the tissue up before we bring it out. So the minute it leaves the patient, it will go up to pathology. And like Dr. Santi said, it's rare that it would take more than half an hour from the time that tumor comes out of the patient to it's getting processed.
Good. And so one other thing that I have to highlight, and I think is true, this is what Dr. Storm always told me, At CHOP, all the tissue goes to pathology from the OR. There are hospitals in which the neurosurgeon give out directly the tissue for freezing or for other experiment. As far as I know, let's not investigate more, we receive everything in pathology because we always consider that the clinical diagnosis is at the end very important. And now, with the frozen tissue that we do, we have to send for molecular, we have to send for methylation. So there are many other clinical aspects that needs to be considered. Now, the problem is, how do we freeze the tissue? As you can see here, you can choose, like in your menu. So the dry ice technique, it is used at CHOP for banking all the other tissue beside the brain. We bank almost everything. But it's not the perfect way because there is no complete stability in the way in which the tissue freezes. Let's leave it the pellet that, yes, is done for the other banking. The isopentane and propane would be a perfect system, but is extremely cumbersome. We do that, you need the liquid nitrogen, you need the isopentane, you need specific equipment. We do that only for the skeletal muscle biopsy that are, I can tell you, not more than 50 a year. In our best year, reach 100 in 1 year. We use the direct liquid nitrogen, and the fresh tissue freezing is done for morphology to give an answer to Dr. Storm regarding the type of tumor. So,
I'd just like to say for those on social media, I can unequivocally confirm every single piece of pathologic tissue goes to pathology.
And we treat all of them as a piece of gold. So then if we look to the liquid nitrogen, there are two techniques can be used. The liquid nitrogen, liquid phase, or the vapor of the liquid nitrogen. We use the liquid nitrogen directly and not the vapor. The vapor is what the NIH would recommend if you are part of for the tumor of the CPTAC protocol. Not many of a CHOP tumor can be enrolled in a CPTAC protocol due to the type of tumor and require a specific equipment that at the moment we do not have. So this is how you do in the liquid nitrogen vapor. The tissue will remain in the phase that is a minus 150, so will freeze in the vapor, never touching the liquid. However, you require absolutely this type of equipment in which the liquid phase never in contact with the vapor phase. The equipment is complicated to manage and to maintain. So what were we doing? In the past, we were putting the tissue directly inside a cryo and put the cryo, yes, in liquid nitrogen, but in the liquid phase. This is dangerous because when you extract this tube and to put it back in the freezer, we had the cases in which by accident the liquid nitrogen penetrate inside the tube and they exploded. And if they exploded on your face, can be quite dangerous. Right now, and then there was the problem that the tissue, when you put it in vial, even if they are cryo vials, they stuck to the wall of the vial. So the people in the lab were complaining that couldn't very easily to detach the tissue. So we came out with this solution. We have the liquid nitrogen. We throw the tissue directly in the liquid nitrogen after it finished to boil. And then at that point, the tissue is a solid piece, can go inside the cryovial. We put this at minus 80 until the people from the bank arrive, take this in in ice, transferred to the bank where they remain at, I think, minus 150 or at least minus 80. If we have the priority, how this the system is designed by the CBTN is that first the tissue goes for the clinical, then we freeze the tissue, and if we have a lot of tissue, let's say a big tumor, whatever is not used in directly liquid nitrogen, we put it in the freezing media, the DMSO, and then we put it inside a freezing container that provide a freezing rate that is very low. This is used for the cell line, or I mean, because you do not kill in this situation the cells. And if we have even more, we can place it in cell culture, such as the RPMI. And then I call Matthias, I tell him that he has to start to run, to come as soon as possible. My tolerance is normally very limited, and normally in the next 30 minutes it will start. Of course, this almost always happens at 7:38 in the evening. And so this summarize what we do. So basically whatever I told you so far is here represented. Thanks to our technician, we have a technician, Samantha, that is fully dedicated to this helping for these things. And then what we do with these samples, and here we directly connect with what Matthias said before. So for the surgical resection, this is everything we can get. Matthias told you how many samples. The collection of the CBTN actually started exactly in November of 2011. And then we have the collection from the autopsy donation. Exclusively as CBTN, the autopsy donation started in 2016. We collected 45 cases because we stopped the period of COVID. There was definitely a period in which we couldn't do any extraction of brain of spinal cord in hospital setting. So we are starting only right now, and a new equipment has been bought that requires sewing the bone in a specific condition to avoid the spreading of viruses. And with this, thank you to everybody.